Can you take this up? Band up? This I should tell?
This point, tibial tuberosity.
Very good.
My thumb.
And other hand?
Left is.
Okay, other hand? Other part of the hand?
In fossa.
Fossa.
Popliteal.
Popliteal. Oh. Popliteal fossa is in the femur, not in tibia.
There.
Mobilization.
Okay, what is happening?
Uh,
Guys, what is the tibial surface?
Tibial surface. Convex.
Concave.
Concave.
Concave?
Convex.
Concave?
والله
Concave?
Convex.
Convex?
Convex.
I've given you 7, right? I will make it minus.
Yeah, Luis.
Concave. Doctor, both convex.
Both convex? Mashallah.
One convex.
Yeah, and there is meniscus, two meniscus between the joint and make it concave and convex.
Come back, Muhammad. Come back again. I didn't understand. One is concave, yeah?
Symmetrical. It's not.
Yeah, but only thing is what is happening is it is straight. Okay, but the menisci deepens it. The menisci is a wedge shape. Okay, but right now the menisci is itself a part of tibia. Yes or no? Is menisci different from tibia? I have to get.
Is meniscus part?
Menisci is a part of tibia. Menisci is a part, though it's a different structure.
Fixed. It's only fixed.
It's a cartilage, but it's a part of tibia because it is fixed to tibia.
Yes.
It is not fixed to femur.
femur.
You understand what my point is? It's a cartilage. I agree. Okay, it's a cartilage. It is basically used to deepen the structure of tibia, for that the joint should move. But during mobilization, we can't take menisci as different, tibia as different, because it is attached to tibia. So for us right now, while doing doing mobilization, which is concave, the tibia is concave,
And the
whereas
femur is convex.
femur is convex. Okay, start.
Posterior glide
Okay.
and
What will happen when I give posterior glide?
posterior glide flex.
Why?
Increase flexion.
Bandar, answer the question.
Answer here.
Tibia, concave, direction, same direction.
When I move
Posterior slide,
posterior slide,
increase flexion.
when I move
Same.
a concave surface,
Okay.
when I am moving a concave surface, the direction of the movement is same as the direction of the glide. That's why when I'm going a posterior glide, there is increase in flexion. Guys, if you don't know this answer, I can't help. Right? Okay, to be more clear. What he has done is absolutely right, not a problem. But guys, if you don't know the explanation, it's completely different. What I do is, the femur is fixed, the femur bone is fixed, the tibia bone, I'm just giving a support with my legs. What I do is, I palpate the tibial tuberosity. This is the femoral condyle. This is the tibial condyle, this is the femoral condyle. What I do is, I palpate the condyle, I palpate the tibial tuberosity, I curl my hand to the complete tibial condyle and fix my thumb on the tibial tuberosity. After fixing my hand up and down, what I do is, come back, Mom. No, front. Yeah. Okay. What I do is I give a posterior glide. Ah, what a chair! Give me that stool. Because my surface is only not proper. Now I fix this, I curl my and then give a posterior glide. Okay. So my pressure is on the tibial tuberosity so that I can push the joint, push the tibia posteriorly. So a concave surface moves posteriorly, so the long axis also moves posteriorly. Thereby my posterior glide increases my flexion range. Now coming to anterior glide, same position. Only thing is, now the force will be from my fingers. The fingers which are curled behind. Okay. Now I'm going to pull it front. I'm going to stabilize this and I'm going to pull it front.
The same.
The same. The handling technique is same. The position of the hold is same. If I push it back, posterior glide for flexion, whereas I'm pulling it forward, it's extension. In orthopedic, when you go further, when you study in orthopedic level, this is also called as Drower's test. This is also called as Drower's test. Do you know drawer? Drawer. What is drawer? Drawer.
Yeah.
Yes, yes. No.
Any table in the office, there is a drawer. So something like that. What you do? You pull it, you close it. You pull it, you close it. Same way. You pull it, you close it. This, if there is any injury to the ligament, the anterior cruciate ligament, the cruciate ligament, if there is injury, as soon as I pull this, the leg will come out like this. If there is injury to the ligament, pain is there, but the movement of the bone. Now see, if I'm pulling, can you see the bone coming out? No, you cannot see. You can feel.
No.
You can only feel. Okay, but in a person with anterior cruciate ligament injury, okay, you can see the whole this tibia coming out, and the movement is very easy. But that is in orthopedic. It's okay. You can forget it right now. Forget right now for you at this level 5 is important is how to do mobilization for the knee. Okay, be careful. Any ligament injury case, mobilization is strict contraindication. Remember? I have told you what are the contraindications for mobilization, in which ligament injury is there. Is that clear? So, holding the tibial tuberosity, curling the fingers and pushing the tibia posteriorly causes posterior glide, increases flexion. Whereas now curling the fingers and the thumb supporting the tibial tuberosity, pulling the tibia anteriorly gives anterior glide, increases extension range. Is that clear? Any doubt? Okay, go back.
There is lateral or medial.
No, there is no lateral medial. Come in, please. Can you remove yourself? Is it clear, guys? Now, coming back to ankle. Sit. Coming to ankle. Now, ankle joint. What all structure are there? In ankle joint, what are the composition of ankle joint?
Calcaneus.
Talus.
Tarsal bone.
Tarsal
Posterior surface of
Lateral malleolus,
tibia.
medial,
Cuboid and
talus.
Okay, guys,
Calcaneus.
don't be perfect anterior surface, superior surface. Tell me the bones. Tell me the joints first. Be simple.
Fibula.
Don't jump to a hyper level. Huh?
Fibula attached to a.
Lateral end, lateral malleoli is the part of tibia. Is the part of fibula. Sorry. Then
Medial,
medial malleoli, part of tibia. Then
talus.
talus. Okay. These three are the structure which make up ankle joint. These three are the structure. Now this, if I take this as a structure, once this structure, if I take it as medial malleoli, this structure, if I take it as lateral malleoli, then the person who sits here is talus.
Yeah, talus.
Okay, and this, what is there is dorsiflexion and plantarflexion, which occurs in ankle joint. Understand? So this is called as ankle mortise. The name of it is called as ankle mortise. Okay, mortise is nothing but a cup with a T. This is a cup, right? Cup formed by what? Medial malleoli and lateral malleoli. And then a person sitting, a bone. Now this is what happens, this is what is ankle joint. Because of this structure, there is dorsiflexion and plantarflexion. After any injury to the ankle, patient has a problem in dorsiflexion and plantarflexion. Okay. There's one more joint here. What is that joint?
That's up to
Perfect. Subtalar joint. What is the composition of subtalar joint?
impatient
That is a movement. What is the composition?
Talus and
Talus and calcaneum. Perfect. Now talus is there and calcaneum is there. Any movement below the ankle joint, there's again a joint. After the talus, talocalcaneal joint. Talocalcaneal joint is also called as subtalar joint. Guys, both are different. Both are different. If anyone says inversion movement, it is subtalar joint. If person says dorsiflexion, plantarflexion, it's ankle joint. Both are not same. Please don't get confused.
stiff.
I'm telling you repeatedly. Stiff, if person says that, doctor, there's a problem in inversion,
Subtalar.
you have to think that it's the problem in subtalar joint. Doctor, I cannot do dorsiflexion, plantarflexion.
Ankle joint.
It's ankle joint. There you do anything with calcaneum, nothing will happen. Because the problem is in, stiffness is in
Ankle joint.
ankle joint. Understand this, guys? Make it point clear. Now, how to mobilize this? Now, as soon as, see, if I keep a hand on my lateral malleoli, okay, and keep a finger cupped like this on my medial malleoli, exactly at the web space is my talus. Exactly at the web is my talus. Okay, now, what happens is, talus cannot be palpated so easily because that bone is inside and many muscle tendons are up. So you cannot palpate it easily. So what you have to do is, basically, what the people do is, I'll come that side. It's easy for me. Okay. What people do is, okay, just go back a little. Have the patient ankle outside the bed, at the edge of the bed. Take the patient's ankle at the edge of the bed. Now what we have to do is basically, take the foot to dorsiflexion, or if you can, hold the medial malleoli and the lateral malleoli. Okay, hold the medial malleoli and lateral malleoli and push the whole foot downwards. Push the whole foot downwards. Now when I push this whole foot downwards, what happens is I'm actually pushing the metatarsals, I'm pushing the cuneiform and all, I'm pushing the calcaneum downward also. That whole set, when I'm pushing, it takes the talus also down because I'm fixing the tibia and fibula. You understand? Because I am fixing the tibia and fibula, when I move the foot, what happens is the whole set, like the talus, the calcaneum, the cuneiforms, and the tarsals, all become one unit. All become one unit, and thereby mobilization is easy. You understand? So pushing downwards is what now? Posterior glide. Okay. Now I am doing a posterior glide. Now what is the range of motion increased?
Dorsiflexion.
Why?
Convex opposite.
Which is convex now?
Complex tibia. No.
Talus,
Tibia.
tibia is convex.
Concave.
Guys, still you are confused with means you don't know bone anything. How is the bone? I'm telling you this. What is this?
Concave.
Concave is convex.
Then
Tibia concave.
Tibia concave.
Talus convex.
Talus convex.
then how can you get confused when I'm showing you all the figures? God, please help me. Whom should I go and where should I hit my head? Tell me one big stone. Medina, I can't go to hit that stone there. Okay, push downwards. Okay, push it downwards. So the movement, what is happening is posterior gliding for the talus. Now talus is a convex bone. Talus is a convex bone. So Convex going in one direction, what will happen to the long axis?
Opposite.
Opposite. What is the opposite direction?
Dorsiflexion.
Opposite is dorsiflexion. Why do you think so much to answer one answer? So, my posterior glide in ankle increases my dorsiflexion. Clear this, guys? My posterior glide in the ankle create dorsiflexion, increases dorsiflexion. Remember this. Okay? See, guys, if you know the concepts, everything is easy. I told you, please learn the concept. I don't know whether it goes dorsiflexion or plantar flexion. I don't know. I know only the concept. I know concept. If concave moves, same direction. Convex moves, opposite direction. I know only this. I don't know anything else. I apply the same concept in every joint. Can't you do that? One sentence, can't you put it in your head? Why are you all horse again and again? Okay. Now, can anyone tell me how can I do an anterior glide right now? Excellent. Now go to prone, come down. Okay. Again, the same concept. Okay, again the same thing. Now hold the tibia fibula, okay, the medial malleus and lateral malleus. Now hold the complete set of your calcaneum and then push it downwards. When you push it downwards, there is which glide?
Anterior.
Anterior glide. Now this anterior glide in ankle causes what? Increase in plantar flexion. Is that concept clear? Any doubts? Any doubts, guys?
Subtalar.
Subtalar. Usually subtalar mobilization is not done that commonly. Okay. Because the problem is patient will come to you with a problem of I'm not able to walk. Walking doesn't need subtalar movement. Walking needs movement at dorsine and ankle section. You got my point? And the people coming with you here for mobilization of ankle only after an injury to the ligament or fracture at the ankle mortise. Fracture of the ankle mortise. This is what is ankle mortise. If any one of bone is broken, if there is change in the deviation. Now what happens is, usually whenever the people fall down, this is medial malleus, this is lateral malleus. If this gets cut, the talus moves outside and there is break in the mortise. Once the ankle mortise is broken, the stability goes off and thereby he cannot walk.
And dislocation happened to the
Dislocation is very rare because it's a very compact area. There is nothing. The